Without further ado, we are so glad to have Miquela Ibrao come and speak with us today. She is an assistant professor at the University of Hawaii at Manoa, Thompson School of Social Work and Public Health. Her research is rooted in her background as a descendant of the Laguna Pueblo Quechan nations. She completed a dual MSW MPH at Washington University in St. Louis, where she was a Butter Center for American Indian Scholar, and received her PhD from the University of Hawaii at Manoa Office of Public Health Studies. She's currently the chair of the health specialization at the Thompson School, co-PI for the Geriatric Workforce Enhancement Program for the Department of Geriatric Medicine, and the associate director for Kūpuna National Resource Center for Native Hawaiian Elders. Her work draws on community-based research methodologies to enhance Indigenous and Kūpuna health, reflecting her commitment to improve the well-being of Indigenous communities through collaborative and culturally sensitive approaches. Thank you so much for being with us today.
Thank you so much for having me. My name is Miquela Ibrao, and I'm going to be talking to you about some of the research that I've done. It's called What Matters to Older Native Hawaiians as a Qualitative Study on Care Preferences. To get us started off, I am going to expand a little bit on my positionality. Thank you for giving me that introduction. But in my research and in my professional life, it's very important that I acknowledge my research positionality and what brings me to the work I'm doing. First, I'd like to say I am Indigenous. My ancestors and relatives are from the Laguna Pueblo of New Mexico. I still have many of my family members live there, and I go back frequently to participate in ceremony I was just back for inauguration in January. And the other side of my family is Quechan in Arizona, and many of my cousins are still there as well. So I grew up in the American Southwest, a little migrant. We traveled between my two tribes and settled in very rural areas across the Navajo Nation and then in city centers, depending on what was happening with my family and my life at the time. So I've spent much of my life, especially my early life, on reservations there, but now I'm currently live in Hawaii. I moved to Hawaii with my partner, my husband, who is Hawaiian, although I'm not, he is Hawaiian. We moved here in 2017, and we have two, almost three, multi-ethnic Indigenous children. As a mother and as a wife and as a daughter-in-law to a Native Hawaiian family, I do my best to act with respect and consideration for the community while recognizing that I am still a guest here on these islands, and I am not Native Hawaiian. I'm not an expert in this culture, so I work with various Native Hawaiian serving organizations to try to strengthen my findings and remain respectful to the community that I try to serve. Professionally, I did receive my Master's of Social Work and Public Health with a concentration in Indigenous health from the Butter Center for American Indian Studies at Washington University in St. Louis. I've been working professionally in Hawaii for almost 6 years. It'll be 6 years next month. I started my professional journey with the UH Department of Geriatric Medicine as the program coordinator for their Geriatric Workforce Enhancement Program. As part of the GWEP, we've been working to educate professionals, families, and caregivers and implement a framework called age-friendly health systems across the state. If you're unfamiliar with it, I'll talk more about it during my presentation. I've been a member of the National GWEP Indigenous Peoples Consortium, which is a group of GWEPs that work with Indigenous populations across the United States. I obtained my PhD in public health from the University of Hawaiʻi at Mānoa in December of 2023. And the research that I'm presenting to you today was part of my dissertation. It was one of the 3 studies that I had to do for my dissertation on age-friendly health systems. I was hired as an assistant professor with the Department of Social Work in August of this year, and I'm rounding the corner on finishing out my first year as our health specialization chair and first year as associate director for Kūpuna. To get us started, the United States older adult population has grown significantly as the baby boomer era has reached a retirement age and life expectancies have continued to increase. In 2020, 17% of the US population was over the age of 65, which was nearly a 4% increase from 2010. We have continued to see these rapidly aging national populations across the globe, and it's expected to continue to increase over the next 20 years. Life expectancies for Indigenous peoples has also continued to grow, but it is approximately 5.5 years less than the national average, although this number varies by Indigenous groups. Life expectancies are impacted by higher incidences of chronic disease at younger ages, which are brought on by a variety of social inequities experienced by Indigenous peoples. Social determinants of health tend to be more strained with Indigenous populations. They live in rural areas with less access to healthcare services. When they are in urban areas, they're less likely to get patient-centered care or culturally relevant care that really impacts the quality of care that they're receiving. In Hawaii, we see that Hawaii has more older adults. We have more Kūpuna than the national average. Hawaii, about 19% of our population is over the age of 65, while the national average is 17% over the age of 65. Hawaii life expectancies are among the highest in the US as well. On average, we live about 81 years, while Native Hawaiian women live about 79 years and Native Hawaiian men live about 74, which is 4 years less than their white counterparts and 10 years less than their Chinese counterparts. Healthy life expectancies, or the number of years you can expect to live with full health before things like chronic disease impact your quality of life, is also shorter. It's about 63 years for Native Hawaiian women and 61 years for Native Hawaiian men, which is, if it will advance, 10 years less than whites. And I think about 15 years less than Chinese, which is really drastic. We do have a report coming out pretty soon that has updated life expectancies. These were pulled from a couple of years ago, and you see that our state life expectancy has gone up. I think it's like 83 or 85 is the average. And Native Hawaiians have gone up as well, but it doesn't close that disparity gap, that 4-year gap. It continues to trend up just in a same line, right? Everybody goes up the same amount, and there still is this disparity between Native Hawaiians and whites or Chinese, and even more between the top groups and Pacific Islanders, for example. Among Indigenous populations, an elder isn't really a number. It's someone that is a keeper of cultural and traditional and communal knowledge. So for Native Hawaiians or for my tribes, elders are the community members that you look to for leadership and guidance and cultural continuity. It's not really a number. It's this, an elder is somebody that you look to for guidance and for care. They're the leaders of our community in a lot of ways. Kūpuna are integral to the health of communities, and their lessons and community contributions strengthen the health of community members across the lifespan, which is why it's so important that we support their ability to age and age in place, that they're able to age with their communities and pass on their knowledge and be an integral part of their communities. I really liked this quote. For anybody who's driving, I'll read it aloud. America's Indigenous peoples need targeted and sustained help to prevent the loss of our elders that goes hand in hand with the loss of our cultures and languages. And that was from Kai Kahele, a former US representative. So definitions of healthy aging really vary across cultures and settings. However, the medical consensus has been that older adults need multifaceted supports to maximize their health and longevity. The support of a healthcare system is important, with an estimated 30% of older adults ages 65 years plus needing care from a team of healthcare providers that specialize in geriatric care, which entails increased healthcare usage, especially for those older adults who have multiple chronic conditions. Recognizing that the US public health organizations have recognized that we have this really rapidly aging national population, and to try to address it, they've embraced this healthcare model, the age-friendly health systems movement, and the 4 M's framework as a model to create change. Age-Friendly Health Systems is a collaboration between the Health Resources and Services Administration, the John A. Hartford Foundation, and the Institute for Healthcare Improvement. And the goals of this movement is to transform healthcare through implementation of procedures that support the 4 M's of geriatrics, which are mentation, mobility, medication, and what matters. The 4 M's are based on evidence-based practices that support healthy aging in Western healthcare settings. And it includes the regular assessment of geriatric concerns that impact quality of life and longevity. Essentially, they're wanting us to assess for mobility routinely. They want us to look at what an older adult's falls risk is. And if we're assessing it and intervening, it's supposed to result in patient outcomes, less falls. With medications, they want us to be doing routine medication reviews to make sure that we're deprescribing when possible so that we're having less drug-to-drug interactions, that you are making sure that you're not going to have adverse effects with your medications, that everybody's adhering to their medication. And that's supposed to support long-term health, right? Less risk for diabetes or complications from diabetes, for example. I was just in a meeting about that right before this. For mentation, we want to make sure that we're checking on depression and dementia screening regularly for older adults so that we can catch it and address it as early as possible. So HRSA has made educating providers, families, and caregivers on the 4 M's framework a requirement of federally funded programs like the GWEPs. There were 44 GWEPs at the time of this study. Now there are 42 or 41 of us. We had some cuts in this last round. We're focused on educating the healthcare workforce about geriatrics and how to implement these 4 M's. Although originally the framework was a medical model that was really intended for use for healthcare practitioners in a healthcare setting, the prioritization of this model has resulted in it being adapted for use with patients and families and caregivers. The adaptation of the 4 M's framework was the primary focus of our biannual web conference in November 2020, when I first embarked on this research. So transforming the 4 M's model for community use is a really large task. It took years for us to establish it for healthcare use, and it's a tricky concept to adapt for use for communities and families because communities and families are so diverse. So the focus of my dissertation was how do we adapt 3 of these models, but today we're just going to be talking about 1 and making recommendations on how to use the model with Native Hawaiian elders. As we launch into this, I'll talk a little bit more about my partners, but I do want to acknowledge the people that worked on this research with me. First, it was the UH Department of Geriatric Medicine and our GWEP program. And Kūpuna, at the time I was a student, I wasn't associate director yet, but Kūpuna did a lot of the data collection and research, set up a lot of the protocols, and have done a lot of the interaction with the Kūpuna. We're in a stage right now of trying to disseminate the knowledge back to the Kūpuna and doing some action steps from that. We just got back from a visit in Molokai, for example, where we met with Kūpuna. We did a health day. We did a brain health day, and it was a lot of fun. But they've been really committed to collecting the knowledge and then being good stewards of the research and data. And then ALU LIKE Incorporated, who is a Title VI program that distributes a lot of like Meals on Wheels and foods to Native Hawaiian elders. They do a lot of programming, and they're across all of the islands. And the people that we collected this data from were enrolled in ALU LIKE services. And they have been our community partners and stewards of the data and the knowledge as well, participating in they were, in my recent publication, they were co-authors on the paper and walked through the process with me, interpreting the data and creating recommendations. So let's move on to what matters. What matters empowers older adults to decide how they want to age, right? It helps them make personal and medical decisions that enhance their quality of life and happiness. It requires that healthcare teams practice patient-centered care, emphasizing the older adults' autonomy and decision-making power and their ability to age the way that they want to. The formal assessment of what matters for older adults can often be done through medical and legal forms to prepare for end of life. So the advanced care planning that we know is very important, having those documents together. However, approaching it just through legal documentation may seem really impersonal and culturally insensitive for some Indigenous cultures, especially Indigenous cultures that disallow conversations on death, right? What matters should go beyond end-of-life planning and include preferences for how Kūpuna live their daily lives. Discussions on what matters is highly personal and needs to be approached with cultural sensitivity and a trusting relationship. The basic research question for this study that we embarked on was what matters in healthcare to Native Hawaiian Kūpuna. For this, I worked with Kūpuna and ALU LIKE Incorporated. Both of them receive funding from Older Americans Act. ALU LIKE provides a lot of the Kūpuna services, while Kūpuna is a national resource center for the Title VI programs. So we do a lot of research, provide a lot of technical support and education for the Title VI programs. This was a 5-year qualitative interview project with 10 interviews conducted per year. When I started going through the data, we had 20 of those interviews complete. The purpose was to explore Kūpuna experiences with healthcare and identify strategies to enhance that care. Participants were Kūpuna 60 years and older who identified as Native Hawaiian and who had participated in one of the 14 ALU LIKE incorporated programs. And data was collected through a transformative lens through 3 1 to 2 hour interviews conducted via Zoom. I really want to emphasize what a big lift that was, right? We interviewed 30 Kūpuna total by the end of the project. At the time this was done, that was 20 interviews completed, but it wasn't just one interview, it's 3 interviews with each Kūpuna. So that's 60 interviews total. And part of that was done because we wanted to make sure that we were building relationships with the Kūpuna, that we were building trust with them, that we were collecting information that they wanted to hear. We were interested in the healthcare span of it, right? But they wanted to collect stories from their youth and things that they could pass on to the next generation. So that was part of the project. We talked about things that they learned from their Kūpuna and things that they wanted to pass on to their mo'opuna, their grandchildren. And we provided them with packets so that they could pass it on. It took a lot of time, and it's really beautiful to read through those interviews. We got a good connection with them, which was fortunate because this project was originally envisioned as in-person data collection that would happen over a couple of days, and then COVID happened, and everything had to go on Zoom. So it was a crazy time. There was a lot of teaching Kūpuna how to use Zoom to be able to do this. And the ALU LIKE staff were really integral to helping set up that process so that these interviews could be collected. So the first 2 interviews I didn't focus on, I didn't take data from, but the 3rd interview I did, and that was the interview on healthcare services and programs. Questions on there for those who are driving, I will read them just very briefly. Question 1 was, tell me about what kind of healthcare practices your ohana engaged in when you were growing up. To what extent did your family take care of healthiness at home, and to what extent did they consult cultural practitioners or medical professionals? Question 2 was, where do you receive healthcare services today? Question 3, describe a positive experience with a healthcare provider and what made it positive. I think I'm on 4 now. Describe a negative experience with a healthcare provider and what made it negative. How could this experience have been more improved? 5, what makes you comfortable with a provider? What is important for you in building a trust in a provider? 6, how should service providers learn more about Hawaiian community and culture? 7, what senior programs have you really enjoyed? What about them do you enjoy? 8, what programs or services would you like to see more of? 9, what have been your experiences with caregiving your older family members? 10, what do you hope for your own care when you get older and might need everyday help? And 11, what key messages would you like health and social service providers to hear? So this was technically a secondary data analysis, which I conducted using in vivo software. I've been familiar with the project and following it since it was conceived 5 years ago. As part of my role with GWEP, we wrote a letter of support and asked that we look at what matters in these questions. But I didn't physically do the data collection. It was the Kūpuna team and GAs that did it. We used 2 different coding strategies to do this, which were established using the coding manual for qualitative researchers. First, we used deductive coding, which was done with these predetermined codes that were taken from the IHI Age-Friendly Health Systems guidelines on what matters in the 4Ms framework. These guidelines direct providers on how to gain and understand a patient's health goals, preferences for day-to-day care, and preferences for end-of-life care. So the codes we used were health goal, health outcome goals, values, and activities that matter most to an individual, help improve health and could be impacted by decline on health that can guide decision-making, care, which is care preferences, and end of life, which is end-of-life care. So you read through all of the interviews and you put them into these big coding buckets. And then from there, we used an inductive coding methodology to look beyond these generalized definitions of what matters and create themes that were more culturally relevant and specific to the Kūpuna who are interviewed in the study. Rigor was assured following recommended standards for secondary qualitative research. Specifically, I was only provided the 3rd interview for the transcripts for this study. They were provided to me clean of any other codes, so I wouldn't have any biases associated with them. I took a lot of time to become familiar with the data, reading the interviews through multiple times, and then requesting contextual clarification from the research team if needed. Like if they referred to a previous interview and I wasn't sure what they were talking about, I would ask and they would give me context. I met with the team to review codes and themes, and we engaged in this cyclical process of discussion on the validity of the coding methodology, whether we felt like the themes were actually credible, and how they actually fit into the What Matters framework. And then we talked a lot about what novel practice recommendations could be made based on the findings. This 5-year interview project was approved by our UH Institutional Review Board at the University of Hawaiʻi at Mānoa. For the secondary data analysis, the What Matters project was presented to and approved to the research team, which included the ALU LIKE Incorporated Kūpuna Program Director and the Kūpuna Advisory Board. And then although I was familiar with the project since it began, I was added to the team for this data analysis. Specifically, I was added to the IRB so that it complied with the stipulations of our IRB, and we made sure that we were complying to the stipulation of the intent for why the interviews were collected, right? We were looking at healthcare practices, and we wanted to make sure that we were actually honoring the voices of the Kūpuna and why they shared their stories. So participants were distributed across 4 of the 5 islands. 20% were on Kauai, 20 in Maui, 20 in Molokai, and then 40% of them were from the Big Island of Hawaii. We focused specifically on the rural, the more rural, our sister islands for the beginning of this data project, and didn't collect voices from Oahu until the very end. So they weren't ready by the time I was doing this research. Gender, 90% of them were female, 5% were male, and 5% were other. We had a participant who was Mahuahine. Age ranged from 60 to 69, 30% of them were 60 to 69, 45% were 70 to 79, and 25% were 80 to 89. 30% had obtained a high school degree, 65% a college degree, and 5% a graduate level degree of some kind. 20% said they lived in urban areas, 37% said suburban, and 42% said they lived in rural areas. 100% had routine health care of some kind, whether that was a primary care physician or they visited a clinic routinely, and 100% had health insurance. Theme 1 was that we saw there was an incorporation of traditional medicines into routine healthcare. 90% said they grew up using traditional medicine, and 70% continued to use traditional medicine as part of their routine healthcare. Participant 1 here is talking about their use of traditional medicine in their childhood. When we got sick, we never liked to get sick because of the medicines that we used. It wasn't from the doctors, you know. My mom had her own medicine that was picked from the yard and stuff that we had in our yard to use, like the uhaloa root. You know, like you get sick and you get hano, you cannot breathe good. You know, she makes this uhaloa root, and the uhaloa was like, it was so bitter, you know. You had to chew it up, and that's how you ingested it. Which I talked to my mother-in-law, and she said that they used to chew this too, and that it tasted really bitter. I don't know if I want to try it. Participant 2 is talking about their continued use of traditional medicine today. I also believe in extra herbal medicinal help instead of a doctor. So I might make me not very in tune with the doctors, but I do know it works. Participant 3 here again is talking about their continued use of traditional medicines, with again an acknowledgement that they seem to feel that their doctors wouldn't like it, although it's not clear whether they have ever talked to their doctors about it. They said, you know, sometimes when they prescribe medication and all that, you know, sometimes we think, well, let's go the Hawaiian way, you know, medicine or like tea or whatever. I mean, I'm not going to tell the doctor that, but you know, if they do that to me, it's like, I'll just try this way, you know, the way I believe is going to help me. Because taking medication to me, it's all chemical, I guess. We're putting in our body, yeah. The use of traditional medicine, our preference for them wasn't universal across all of our participants, though. There were ones that said they adhere to contemporary medicine regimes, like participant 4, who said, and it's up to us to really to embrace, you know, the medicine, the new medicine. And it's important that we need to follow the directions. And for me, I have to make sure that my medication is updated and make sure that I have enough of the medication that I'm taking that will help me care for myself. Theme 2 was a strong sense of family as part of the decision-making process. 100% expressed that ohana was important, and 90% stated ohana is essential for their ability to access healthcare and their decision-making process. Here, participant 1 talked about the importance of family being involved in their healthcare decision-making process and advanced care planning. I think what's important is for healthcare providers to make sure that the family knows of the options that we have and making sure that the paperwork and their wishes are made known and it's documented. Participant 2 talked about how their ohana was really involved in their care, even when they didn't reach out to ask for help. But I didn't tell them because my family going to get all, you know, hyper. So I drive to the hospital. But then when they come, because they hear I'm there and they see my car in the parking lot, they go, how did you come? And I go, I drove myself. And here the participant laughs and they go, oh my gosh. I go, no, I'm okay. I was okay. I'm okay. And for anybody who's lived in a rural area or like close to their hospital, this probably feels really familiar, right? Everybody knows where you are before you can tell them. Participant 3 talked about the extended concept of ohana. The people I grew up with, okay, their children, some of them wasn't even blood related yet. Auntie, you think I can come to your house with Tutu? And I said, because they already know she was passing, right? She only had so many days left. I said, oh, yeah. Because that's how family is back home. Not because you're related, yet you are related because you all ate out of the same pueblo. So these children are calling me auntie, you think, because my own, you know, nieces and nephews, grandnieces, they all said, auntie, you think you can come over? And I said, yeah. So, you know, all these children are gathered around, and I was thankful for that. Theme 3 was on preferences for home-based care at the end of life. 100% preferred to remain at home with help from ohana and services, but noted service shortages in their areas. 75% had discussed their end-of-life goals with their ohana, and 65% preferred to die at home, although 55% of those 65% did not want to burden their families. So participant 1 here talked about their preferences for home-based care and their plan for their family to take care of them. I prefer to be home, you know, because when I see some of my friends at the care home or even the hospice, it's sad you know, and I have to say, my son said, "Mom, don't worry, I'll take care of you." Participant 2 also expressed a preference for home-based care, but was unwilling to allow their kids to take care of them. I told my kids, if I get really, really cannot take care of myself, I don't want them to have them take care of me. I want them to take me to the nursing home. So because I told them, I feel that my time was so different from now, your time, because maybe my time I had to do it. But nowadays, their time, it's hard for them to take care of children and somebody that's sick. I want them, on paper, I said, I want them to take me to the nursing home. There was frustration among some of the participants who felt unable to age in place and in their home and close to their aina. Like this participant who said, "So why should the people of my island move that way? What happened to us here? Why are we considered non-existent? Why? Because we are on Medicaid, Medicare, food stamps. We don't make enough money for everybody to come this way." And finally, again, here we see an emphasis on advanced care planning and talking to the family at end of life. Advanced health directives is important. What if you can't speak anymore? But if you have that done ahead, then nobody has to question or have fight, you know? I've seen too many of that happen. Finally, this is our last theme, the importance of provider relationship building. 75% reported trust is essential and is strengthened by talk story and connection. 65% wanted providers to learn about their culture and connect with community. And approximately 60% valued honesty and the ability to communicate in lay language. This participant said there's no relationship with this practitioner nurse. She was just in and out, and I felt that, and like everybody, and I like her too, you know, but I felt like we didn't have that kind of relationship, you know, the concern, you know, on a different level, you know. And then this one, speaking to a provider, you need to talk at my level, because I don't really understand all these doctors, you know, all these biological words you guys using with me. And, you know, your guys' terminology is so different from ours. You know what I mean? So you need to come down to earth with me and talk to me in my language. Tell me what's happening, you know? So they explain, and that's what I really love about my doctors. They explain to you, they tell you what they're going to do. They tell you what you're going through this, and that makes you feel so comfortable, especially in the nurses. The really interesting part about that was that multiple people said that they valued honesty even when the news was bad. You know, they wanted to know honestly what was happening, and they wanted to understand what was happening. They didn't really want it sugar-coated. So there are limitations to the studies, specifically that we didn't ask about the 3 IHI and What Matters categories on health goals and preferences and end-of-life care. The questions were implied in the document, but were written in a much more conversational way, right? This was technically a secondary data analysis. I did not conduct the interviews, and I could be missing out on vital content. I was very, very grateful that I had the voices of the research team that did collect the data that I could rely on, that made it more relevant. And there is a volunteer bias with this. Often, and you saw how it was very heavily female. It was largely educated. There were a high number of people that were insured. And if we had gone outside of the ALU LIKE recruitment bubble, those may have looked different. But there is a trend in qualitative research where women tend to volunteer for this disproportionately to begin with. For the conclusions and recommendations of our study, the major findings on what mattered included the importance to understand what matters in context of family and community, talking story, and building trust. We need to make sure that we're training providers in patient-centered, culturally relevant care in order to connect with the populations that they serve. We should be supporting minority enrollment in medical fields, supporting Native Hawaiians to pursue education and health professions. It has the ability to make healthcare settings friendlier, enhance culturally relevant care for Kūpuna. The value of encouraging minority enrollment in healthcare fields is not new. It's something that has been well studied and the barriers to enrollment and then to graduation are well documented, especially for those who are first generation college and low socioeconomic status. However, with the ending of affirmative action in 2023, with that Supreme Court ruling and the current administration with rolling back of equity-based admissions practices, I feel it's more important than ever that we continue to acknowledge that it is important to be supporting minority enrollment in healthcare fields, whether that's doctors, social workers, nurses. We have a very large healthcare professional network, and we need to try to be supporting them and providing mentorship to them at all levels, right? It's not just getting them into school and then graduated from school. It's mentoring early career professionals to make sure that they can become healthcare professionals, that they continue to advance in their career fields and get opportunities. And I mean, that comes from the university level, trying to make sure that that's ingrained in there, but also just in our healthcare networks, right? I really like the idea of designing healthcare centers that are integrated into community settings and encouraging participation in community events to build a sense of community. There is a disconnect from hospital settings that seem sterile and Western and community settings that are integrated and visit inside of community and feel more holistic, right? And then the final recommendation was the incorporation of traditional practitioners into care teams. But this would have to be done with respect for the profession itself, with an understanding of Pilina, or relationship and connection, and how that is a slow process. We live in a world where healthcare encounters are 10 minutes, and that is not appropriate for a traditional practitioner. We need to have more time to connect and build those relationships for the medicine to work. This we'll go through just very quickly. The findings were, we really like frameworks in research and to double check ourselves and see if we're communicating things correctly. So this was double checked against the 7 Sacred Indigenous Public Directions, Indigenous Public Health Framework from the University of Washington, which I really liked. And this was above the integration of holistic wellness, which is essential for health systems, not just to address the symptoms and sickness, but to promote health across the lifespan. Below is cultural identity, making sure that we are respecting culture and incorporating it into our practices. The center is families and communities and their importance to Indigenous life and prospering. The south is service, and emphasizing the importance of Indigenous people being part of the health workforce. East is knowledge, making sure that we are promoting Indigenous knowledge as valid and essential in our healthcare practices. And then we have North, which is respect for sovereignty, and West, which is tribal governance, which were outside of the scope of this, but very beautiful and important to support. So, results from my overall dissertation recommended that we have a 5th M attached to the age-friendly health systems framework. We don't just focus on what matters, medication, mind, and mobility. We focus on multicultural as well, and the impact of culture on our healthcare experiences and the things that we find important as we age. The results of this were published in the Journal of American Geriatrics, and I can put a link to the article if anybody would like to read it. It's a broad overview. And then finally, recommendations from this study were developed into an infographic that will be available on the Kūpuna website soon. It hasn't been updated yet, but I can also provide that to whoever's interested if you email me. And that is the end.
Great. Well, thank you so much. That was really what a great presentation and also really interesting information. So thank you. People can put things in the chat or raise their hands. Those were all recommendations that don't sound crazy at all. I don't know how much of that you see. So maybe I was wondering about traditional medicine. Like I'm familiar with Waimanalo Health Center, that they're doing some things, and Waianae Coast. How common is it that people are integrating traditional medicine in? So I know that, as you say, it takes a long time to do that.
It does, and I've heard about Waimanalo and Waianae as well. Aloha Care has a program for traditional medicine that has been really, really supporting that. And I know that Ke'ili with Papaola Lokahi has been working a lot on this project, trying to integrate traditional medicines into healthcare practitioner settings, but also like trying to build a network of cultural practitioners here. So he would be a much better person to speak to that. We've been talking about it on and off for the last year, but I'm not an expert on that. So I don't want to speak to something I'm not
Yeah.
totally informed on what their next initiatives are.
Right. Well, yes, and shout out to Aloha Care for, I think, being the first health plan that's actually paying for the Native Hawaiian Ho'oponopono, La'aulapa'au, Lomi Lomi, and then, they're doing a variety of things. So that's, anyway, I'm familiar with what's happening with Waimanalo. So a couple of people asked if you would be willing to share your slides. So
I'm happy to share them. I'll send them as a PDF and you can post them with
yeah,
the thing.
or you could just write to me. It looks like Ed would like to have them. So just send me a note, or if anybody else, send me a note, and I'm happy to share those, to share that information.
Okay, and Melissa would like a link to the journal article.
Alan Gamble had a question. What did you find your greatest challenges were in doing this research?
I think the one that I'm always most worried about is being respectful to the community and the voices that's shared with us. It's a big responsibility to honor those voices and make sure that they're being represented correctly, right? And that was a very big fear of mine when I went into a secondary data analysis. Usually I collect the stories myself, so it was a very big fear. And that would, yeah, it's an ethical challenge to do secondary research with qualitative data. Or at all, we did have to do member checking and making sure that we were working with community organizations, but it's the thing that I think that was definitely my greatest challenge doing this.
Was there anything surprising that you found in the results?
I think how many of them said that they'd already talked to their family about the end of life. That was something that I constantly have to remind myself, like my experience with my indigeneity is different than Native Hawaiians because it's so taboo still with my elders. And it's something we fight about. And it was something that you routinely saw here. People seem to think that talking about it, even if they didn't have documentation, was something that they needed to do. And that might have been a bias of the data set we had, right? They have had services through ALU LIKE. They've probably had multiple people talk to them about advanced directives. I don't know if that would have been across the board, but I was very surprised to see that so present.
Yeah, I was pleasantly surprised about that. I will say, Hope is Native Hawaiian, and she's done lots of talks all over the place with all kinds of people and all of that. So, I mean, I won't say it's all because of Hope, but I think there's a lot of things that are going on out there. But I was surprised at that high number too, because it's sort of that's really that's kind of that's a lot. 75% had talked to their families. Wow. Okay. So maybe
just the
after
ones
all,
that reported, right?
right.
Because we hadn't asked it. It could have been more.
Yeah.
It was really
And then this piece about burdening the family, which I thought was great from your story of the person who drove themselves to the hospital. Like, oh, don't bother, I'll just drive myself, as well. Don't worry. And then we find a lot that families will say, but I want to, and you don't want to have the guilt of not doing it. Like, oh, I didn't want to, oh, you're so busy, never mind, I'll drive myself to the hospital kind of thing. So I thought that was also that 55% not wanting to burden families. That resonates, I think, across ethnicities in Hawaii anyway, even for all sorts of different groups.
I think so too. It was really interesting to see how many of them actually use the word burden. You know, they weren't talking to each other. It wasn't like a group, and they've all decided on burden being what they felt. It was a bunch of individuals that all felt burden, and not wanting to burden their families. And so many of them said that like their families are fighting with them about it. Like, they want to provide care. No,
Interesting combo between, you know, traditional and then what Western medicine asks. So, which is where we are, right? There's a new, the current reality. Like if you choose to not do an advance directive, but then you want care from a Western medical clinic, you have problems. So there has to be a melding, which sounds like you found that.
I think to a lot of love on both sides. You know, Kūpuna, that they want their families to be able to work and take care of the children, right? And then love on the side of the children who wanted to be present for their families.
Right. Yeah, which then the conversations, which was what I love about What Matters, right? If we can have conversations, you can hear that and get over misunderstandings and also understand what people's boundaries actually are. So Chad had a question. I'd like to hear your thoughts on the differences between Western medicine focus on individual autonomy versus Native Hawaiian cultural shared decision-making practices.
Well, I'm not Native Hawaiian, right? So I can't speak too much to that side of it. But the sense that you get, and the sense that I get from my own indigeneity, is that you don't make these decisions without it being like a family discussion, right? It's not something that you're sitting with your doctor and just making those decisions on what do I want. It looks much more like what does my family say, even if I disagree with my family. And it may be a really iterative process that you're fighting about for a while. But that a lot of voices come into that autonomy in that decision making.
Yeah, I don't know if Hope wants to say something, but we, you know, this for the last, you know, Hope has now been with Kukuamau for 7 years, which is crazy, but there were 4 years of a pandemic. And personally, I can't remember when we didn't have Hope here. But it's for us, when we read national things, there's always this emphasis on autonomy. You get to say what you want. And that's not really, that doesn't what comes up here. And over again, that is not what, so we say thank you very much in a very polite way for those suggestions. And again, the whole idea of ohana and what does your family want? And again, not being a burden, but getting the family to talk. I think that is so important, right? That is just so important to facilitate. Again, may not happen in that 10-minute meeting, which is why then we need other venues for having more of those conversations that have then this amazing, those great outcomes where you really can talk to people. Hope, you want to say anything? You're just sitting there happily.
I love the information. Thank you for sharing with us, Miquela. I did see that Dan put something in the chat saying you mentioned something about a bias because these people who participated volunteered, and that they're more likely and willing to discuss end-of-life care preferences. Do you think that was part of it as to why they were so comfortable?
Interview specifically on end-of-life practices, right? It wasn't like they were volunteering to participate in a discussion on end-of-life. It was more one of the questions that some people did skirt around, right? And some people didn't. The supposition for me is that they may have had more reported conversations on advanced care planning because they do get services from ALU LIKE, who does advanced care planning education periodically. Yeah.
I'm curious if maybe the fact that they were in the outer islands, more rural areas, that their view of becoming a burden to their children is a little bit different than if they were here in Honolulu, because there's so much more access to these adult daycares, assisted living facilities, things like that. So I'm wondering if you think that might have played influence on how they were speaking about becoming a burden and things like that.
Absolutely. I mean, I'm very interested to get into the Oahu research and see what differences we see here. Even care homes, right? Which aren't as facility, they're more like in community. But there's so much more access to different care settings and different options here. Which is one of the strains, so many people feeling like they have to come here for their care when they want to stay on their islands. Right.
So Chad has a big word in there. Did you experience any palliative collusion tendencies? As in, an end-of-life person would prefer their family not know about their condition, or maybe if there were family, they would not want to tell their loved ones about their health status.
We did not observe that in any of the studies. Yeah. I mean, there may be like a I don't want to worry them kind of thing on the daily basis, but they weren't actively hiding or I mean, I know that's common in some cultures, completely hiding, right? Diagnoses, and that wasn't observed.
That's good to know, because that's certainly something that does come up in different, in Hawaii, in different ethnicities. Oh, we can't tell grandma that she's so sick, and grandma says, I can't tell the family that I'm so sick, and both of them actually do know it, but yeah. So that's a very good question about that.
There's a beautiful film on that a few years ago.
Right? What was that called about the,
Yeah,
I forget what that was called. It wasn't a Chinese family
yeah,
where they wanted everybody was trying to not tell grandma she was sick, and grandma, of
The
course, was very
Farewell.
clear. Yeah, the farewell.
Yeah,
There you go.
it's a beautiful one.
Great. So I'm just looking to see if there's any more comments for everybody, or any more questions for you. There's lots of good information, and I certainly hope that people will take that on. And, I so appreciate also this comment about speaking in lay language, because we see that so often. No one knows what CPR is really, and yet we say it all the time. Heart failure. Failure is death. What do you mean I have heart failure? I'm not dead. So what does that mean? I think there's so much conversation that needs to happen, and have people talk in a much simpler ways. I did miss that Ed had asked if you were aware that any universities or other groups were actually incorporating the 4Ms, because it's such a big IHI project. Are people here doing that?
People here, we have the Center on Aging working on age-friendly health communities. We've been the major drivers, the age-friendly health systems, but we've been working with Hawaii Primary Care Association on getting a lot of the federally qualified health centers certified in age-friendly health systems. Our next initiative is start working on nursing homes. Most of the major hospitals on Oahu, at least, are age-friendly health system certified, like the Queens, Palimomi, Kaiser. Yeah, we've been trying to promote it over the last 5 years. Nationally, there's a big movement for it. There are 42 different GWAPs working on age-friendly health systems in all of the different states.
Because I've heard about it, but I wasn't aware there was like a formal certification process.
Yeah.
So that's great. Yeah, and as I mentioned, we're, Kūpuna, we do a lot with advanced care planning, so we're really happy to help. And Chad wrote a good opportunity to promote the Hui Pohala videos. Yeah, there's some the ACP decisions videos, so that if folks don't know, those are available through Hui Pohala, and you can, at the moment, those are nice, those are free, and they really want people to use that. So I definitely encourage people to contact Hui Pohala about those ACP decisions videos. Okay, I think we're coming to the end. Dan said in San Diego, that this palliative collusion, that's a new term for me. I like that. That's good. With families from different cultural backgrounds was challenging, but not insurmountable. So yeah, it's always so good to have the interdisciplinary team. Hopefully if people understand what's going on, take some more time to listen. You have some age-friendly health systems module with CMEs. Aha, that's great. Okay.
Yeah, they're stored on the HAH website for anybody that wants more information or who would like more opportunities to gain CMEs.
Great. And you said right now you were going to work now with care homes. Is that what you said?
Nursing homes are the next
Nursing homes.
site. They don't have we keep asking if there's a way to get care homes certified or different levels, but they've expanded to nursing homes so far.
Right. Well, I know Dr. Wen is very involved with that. And so, but anyway, starting with nursing homes sounds like a good plan.
Yeah.
Okay. Well, it's, we're past 4 o'clock. This was really interesting. And I think this has been really interesting and a really good reminder how important Ohana is, traditional medicine, talking with families, all of those things which are important. And I really hope that our health systems and people involved with healthcare can look to your research as confirmation about these things which we know intrinsically are so important. And it's so great to have research again that we can point to and say, yes, it's not just a nice to have, that this is a crucial piece. So that's really important. So I'd like to thank you so much for speaking. Thank you so much for sharing your mana'o, your wisdom with us today. And if people would like to have a copy of the slides, you can send me an email. If there's any other questions, just, you can also reach out to us and I could put you in touch with Professor Ibrao. So thank you very much.